All right, so we'll finish up this section here, and then we'll do the, yes, come on in, stragglers. Any idea what song you want to sing now? What song?
The theme song to Star Wars, of course.
I was going to say you should do the Ewok song from the end of Jedi, and if you could do that, then I would be impressed.
That takes a lot of time.
You need the nub. Da-da-da-da. Yeah, anyway, I'm not here to sing. Okay, so we'll finish up the section and then we'll go into our review via Kahoot, and then that'll be it for the test. So it should be pretty straightforward from that standpoint. So anyway, we were talking about our opioids and addiction and tolerance and all of that. So we can talk about that briefly as it kind of comes up in specific examples. But has anyone heard of E-Force before?
Yes.
What is E-Force?
The bane of providers' existence.
The bane of providers' existence. Why would you say that?
Because they have to do so much more work now to save lives.
What is it? Like, what does it do? Right. So if someone fills a controlled substance in the state of Florida at one of the pharmacies, it gets reported up through E-Force, right? So that means if you go fill hydrocodone, if you get Adderall, anything like that, it gets logged there. Why do we care about that? Why does that matter? Right, because there's a big issue with overprescribing, and we need to be able to look at, as providers, looking to actually go in there and see, like, okay, what have these people been getting filled? Is it legitimate? We can use it from the pharmacy standpoint to see, like, hey, they just filled it like 10 other, CVS's and Walgreens and Publix's, because our pharmacy systems, are they all like interlinked to one another? Not necessarily. If you're like within like one company, like any CVS will have all the information from other CVS's and Walgreens and Publix, so they can all communicate within their own organizations. But if you switch pharmacies, we have no idea what's going on, right? Actually, the only thing that actually gets tracked, like from a federal sort of standpoint, is like pseudoephedrine purchasing, right? That's the only thing that's actually been like nationalized. Anyone know why that is? Anyone remember? Yeah, we're about methamphetamine production, but. Florida being kind of late to the game in a lot of things, like, PAs being able to prescribe controlled substances and things like that. E-Force was a pretty late sort of thing, and a lot of other states did have prescription monitoring programs. And again, this is only for controlled substances. So it used to be an optional thing, right? It used to be something that providers could opt into if they wanted to. Pharmacists could get their own login, providers get their own login. And it's pretty helpful, actually. So for instance, if I had a patient who, say, gets into a car accident, they're unconscious, they have to go to surgery, and they get admitted to the ICU, we want to know what their med list is, but they have no family available, they can't tell us because they're intubated. I could look to see, like, well, they could have filled a controlled substance at some point. Let me look up their stuff. I see they filled at CVS. Great, now I can call CVS and get all their prescription history. That can be really helpful information, right? Did I tell you about the PEDS ER doc that got fooled by a patient with kidney stone pain? So this is before it was mandatory to actually check this stuff, which I'll talk about that in just a few moments here. But we had one patient who's in the PEDS ER that was like in their 30s, and I was like, well, that's very odd. We normally, if you're like a PEDS hospital, sometimes we'll call like a code triage. They have different names for it, but someone has like chest pain, they get triaged down to the ER, they get stabilized, and they get sent out to an adult facility. So it's not uncommon you have like an adult patient. But this one was here for like kidney stone pain, and I was just like, okay, that seems kind of odd. I was looking at it, they're about to get their second dose of Dilaudid, and I said, okay, that's really odd too. I was looking through the stuff, was verifying the orders, and then I looked to see that they were here like 2 days ago for the same thing. I guess they're visiting their kid that was admitted to the hospital, and says, okay, this is very strange. But let me go ahead and check out her E-Force. So I looked it up, and guess what I found? Very interesting information. She had the same name and date of birth, but her address kept changing. It was so strange. It'd be like 2422 Wallaby Way, or it'd be like 24222 Wallaby Way. It would just be like permutations of the same thing, but filling up all these different pharmacies. And I go, huh, that looks very strange, right? So I go over to the provider, and he's a PEDS ER guy, so they assume all their patients are being honest because they're little kids, right? They can't lie. And so I go, hey, did you check out their E-Force? And he's like, no, I didn't check it out. And so I said, well, you should look at this. And he goes, oh, I can't believe it. She seemed like she was in so much pain. I said, yeah, they get pretty good acting about that kind of stuff, And even when you give a UA, you can prick your finger and put blood in there, so it actually looks legitimate, right? And so he's like, oh, well, she's not getting any more drugs from me, so she got transferred out, and then we didn't see her again, right? Because we cut off her access. So stuff like that can happen, right? So was she actually having kidney stone pain? I can't say for sure, but because pain is subjective, as you know. But it seemed odd, right? It seemed illegitimate. And so in those cases there, that can be very helpful information, especially if you have like a printout. You can just take it to them and be like, they're coming in saying they ran out of their pain meds, their dog got into it or got flushed down the toilet, whatever the case may be. He's like, well, you just filled like 200 at like a pharmacy the other day. Like, why is that? And then that is much harder to argue, right? So that has been a very helpful thing. Now, Cam mentioned it's the bane of providers. Why is it a problem?
Because now they have to chart it, they have to constantly be monitoring it.
Exactly. So now this is something that came about as a great segue. House Bill 21 came out, and this is back in 2018, and so this is actually was applied to all controlled substances, not just opioids, but that was the main target of it because it was such a problem in Florida. You'd have these pill mills that were just sending out just tons and tons of drugs. I mean, I had a guest speaker for a class I was doing for a pharmacy school one time, and they were undercover agents for FDLE that basically they worked on like provider diversion and like illegitimate scripts and stuff like that. So they did a lot of work with the pill mills when they were still up and running. And so they go to these like strip malls. We had this like doctor's office that was there, and like the entire parking lot is just like jam packed. There's people around the corner waiting to be seen, and like all the license plates are from all over, Kentucky, West Virginia, and they're like, why are all these people coming here for this particular provider? Do they provide that excellent a service? No, they provided a lot of opioids. And so Florida was kind of the first stop on what they call the OxyContin Express. Anyone ever heard that term before? It was legitimate. Like, so you'd have people coming down by the busload sometimes from places like Kentucky and Virginia, and they would come and they'd like just unload all these people. They get all these scripts filled. Usually they had like a pharmacist that would be in cahoots with the providers to allow all these meds to go out, and then they would ship them back up and then usually use them or sell them or whatever the case may be. And so it was a big driver of the opioid epidemic. So state came in and said, okay, we're trying to shut all this down. A lot of people got arrested. Pill mills got shut down. It was pretty messed up too, because like those officers said that when they would go undercover, I mean, you'd find patients who were like passed out in this waiting room because they were under the influence of the medications there. But some of the providers that they were arresting, they would find like guns in their offices with like the ID numbers like filed off of them. They found one provider who they arrested. He had condoms in his lab coat pocket because he was trading sexual favors for opioid prescriptions. It was awful, right? And addiction makes you do some really awful things. So anyway, so they really try to crack down on a lot of this stuff, and so that's where you start to see this uptick in like heroin use and fentanyl deaths in Florida because the prescription opioids are less available, right? Just because you run out of one thing doesn't mean you stop being addicted. You go to something else. Anyway, so House Bill 21 was aimed to kind of help out a lot with that. So for instance, practitioners have to have certain mandatory training hours during your license renewal period. For opioid use, we have to do this as well as pharmacists. And then they say you must check E-Force before you prescribe any of these controlled substances, right? Now, is there any way that they're actually monitoring that? Not really, right? So a lot of this stuff is, it depends if your organization is doing it, but that is supposed to be one of the things. Anytime you prescribe something controlled as a controlled substance, you should be checking E-Force. It's just a good way to cover your butt, right? So you can actually document there, hey, patient's never filled before, and it's a new script, everything looks legitimate, or I'm denying this patient because of X, Y, and Z. So if they come back and complain, you can say, well, I checked E-Force, and they just filled 100 tabs of OxyContin 3 days ago. That's why I didn't give them anything. So the other big thing that changes as well is the actual scripts themselves, the days supply that you can write for. So for instance, for acute pain, you're limited to a 3-day amount. So you couldn't be prescribing more than 3 days unless you would put on there acute pain exemption, and then you get up to 7 days. Okay, so that was a big change in terms of practice. Actually, I talked to one of my pharmacist buddies who works at a smaller retail pharmacy. I said, like, has this actually like changed the amount of like scripts you're actually getting? Has this actually changed anything in practice? He said at first, no, not really, because a lot of people forget to write the correct amount on there or at the right actual date, so you just call them up, have them change it a lot of times. So it didn't really change much, but maybe as time goes on, we'll see some changes there. The other thing then is if you want to prescribe something more than 7 days, you have to write for non-acute pain. That means it's for a chronic indication, and you should, of course, be documenting that in your charts as well to make sure that you're good from that standpoint, right? Now, again, what do you have to do before you get you're able to prescribe controlled substances? Yeah, so you have to get a DEA license, and again, not all of you will do that. Some of you may. Depends on your job. If it's appropriate, you don't have to.
What are just briefly the timelines for what's maximally you can maximally prescribe for chronic pain for like a Schedule 2, for example?
So, anyone remember those restrictions I mentioned? What's 6 months?
I thought 6 months was for the higher. but 3 through 5.
So 3 through 5, they're only good for up to 6 months, right? And so you could do refills on those. So you could do like an original fill for a month, and then you could do, say, 5 refills, right? For a Schedule 2 substance, how much can you do for? What's the max? 90 days, right? And so usually you wouldn't do more than a month at a time. Sometimes you'll have patients or providers that will like post, say not to fill until this date. So that's what you see with a lot of like amphetamines for ADHD. They'll say, hey, don't fill this one until, you get this one on January 1, then don't fill this one until February 1 until March 1, but no more than 90 days at a time. So it's definitely burdensome from a lot of situations or a lot of cases, especially when like hydrocodone got bumped up from a C3 to a C2. That was another really big change where it made it a lot more restrictive, and that helped to cut down on a lot of those scripts. Anyway, so those are important distinctions to make there. 3-day for acute pain, unless you're acute pain exemption, then you get 7 days, and then if it's for a chronic indication, right, for non-acute pain, right. Anyway, so again, what's a what's a Schedule 1 substance mean?
No therapeutic.
There's no acceptable medical use, right? What are some examples? Marijuana federally is considered a Schedule 1 substance, right? You're finding the states have been kind of dictating their own processes for those. So marijuana is kind of the gray zone, the kind of the odd person out, right? What else would be a Schedule 1 substance? LSD would be a Schedule 1 substance. Heroin would be another good one. You mentioned cocaine. Cocaine is actually a 2, as you said, right? Because there is an acceptable medical use, right? So that's the big difference between Schedule 1 and Schedule 2. Remember, those have the highest abuse potential, right? The highest risk for addiction associated with those medications there, right? Most of your opioid pain relievers are going to fall into this as well. Your Dilaudids, your Fentanyls, all that. We'll talk about those individually when we get to them, right? And again, for a C2, it's much more restrictive in terms of writing. For instance, I could fax over a script for Ativan, a Schedule 3 or Schedule 4 substance. You can't do that with a Schedule 2. It has to be on tamper-evident paper, so they can't go and copy it. And if you do try to copy it, it says void on there or whatever, it says tampered, whatever. And then it has to be hand-signed. You can't just use a stamp or anything like that. So again, it's much more restrictive from that standpoint. So let's get into the individual examples here as we talk about them. So codeine, how good is codeine in terms of like pain relief, if you've ever heard of it before? I think it's like one of those like really big guns, kind of wimpy. Pretty wimpy, yeah. It's actually kind of the wimpiest of the bunch we'll probably talk about here. Usually it's going to be co-formulated with acetaminophen, so Tylenol number 3 is the thing you'll see there most frequently. It's usually 30 milligrams of codeine and 300 of acetaminophen. This one's important because it is converted via CYP2D6 to morphine, so that's the actual active component of there. And so why that is so important is because you're going to find some patients are going to be slow metabolizers of CYP2D6 and some are going to be rapid metabolizers, right? So what implications would that mean for the patients? Say if you're a slow metabolizer, less effect because less of it's getting converted over into morphine, right? If you had an ultra rapid metabolizer, they would get very good effects, so they'd be getting a lot of it converted over to morphine, and that could also increase their toxicities, right? So respiratory depression, CNS depression, euphoria, as well as you can see with that. So because of that, and we don't really have a good test for that, we don't normally know who's going to be a good or slow metabolizer of CYP2D6. There's too much variability, so it's starting to fall out of favor. And in fact, I probably mentioned this back we were talking about pharmacogenomics in kind of a broad sense, but here specifically, we don't even use it for kids anymore for the most part. We took it off formulary at Nemours entirely because there were some issues where kids were actually dying. And so what was happening was there's some cases where kids had obstructive sleep apnea, usually due to their tonsils being enlarged, and so they would go and have them taken out. And after surgery, that tissue is normally nice and calm and good. It's inflamed, right? It gets edematous, it gets swollen, right? And these kids are already used to having that kind of airway being obstructed anyway. And so then some of them are being rapid metabolizers of CYP2D6 are converting all this codeine being given for post-op pain over into morphine. And what does that do to your respiratory drive? Blunted it, right? So then these kids were basically going to sleep and they just never woke up because they stopped breathing, right? So because of that, that's why they were starting to kind of move away from that in a lot of cases here. It was difficult to tell who to be rapid metabolizers. They typically, more often than not, were of Middle Eastern or North African descent, they found that. And actually that makes a lot of sense too because we find a lot of sickle cell patients, or predominantly black, actually a lot of them are managed well on codeine, and that makes sense because they're more likely to be rapid metabolizers, so they probably get more pain relief out of that than, say, someone who, let's say like a white patient, for instance. But anyway, so this is typically more for mild to moderate pain, a lot of variability there. And then depending on the formulation, how it's actually coming, it's usually either like a C5, which we know is the least restrictive out of the bunch, or maybe like a C3. But again, not used as frequently, especially in pediatrics, but you still may see some patients on it. So that leads up into morphine, if you will, right? A lot of different formulations here. This one is you'll see a lot of use of morphine out there. Certainly IV, we use it quite frequently. You can find a lot of oral options, either as, say, for instance, like immediate release. You'll find it as a continuous release. Products, if you see that MS Contin, that's usually going to be an extended release product meant to work, say, over a 8 to 12 hour period or so. And so this also has some interesting implications in terms of its metabolism as well, because it actually forms these glucuronide metabolites, either a 3-glucuronide or a 6-glucuronide. The 6th one is really important here from our purposes because it actually gets cleared through the kidneys. So this can be a problem in elderly patients if they have, say, poor kidney function. They hold on to a lot of this morphine 6-glucuronide, and what do you think may happen? They get overly sedated, or they get respiratory depressed as a result of having all this extra drug around that is still pharmacologically active, right? It's an active metabolite. So that's been a problem too, so we will definitely try to limit use in those elderly patients if they have poor kidney function, for sure. The other thing you're going to see a lot with morphine, you hear about a lot of people with morphine allergies, and typically it's not true. A lot of times it's actually related to histamine release as a result of morphine use. It's pretty known to cause that, and so you can see certainly some itching. You can certainly see even hypotension in some cases. Some patients get really profound hypotension associated with this drug. It's not a real anaphylactic allergy. Some people will have a true allergy to morphine, but more often than not, you can give some, say, diphenhydramine, and that'll help to limit a lot of the side effects. But what's the problem with mixing, say, morphine and diphenhydramine together? A lot of sedation, right? So those will be definitely synergistic working together. If your patient needs to sleep, if you want them to sleep, that may be okay. But in a lot of cases, this can be very, very sedating.
I've seen people in my clinical experience, like not just the morphine but other drugs, and they have like allergies to like all of the opioids. Is that like an opioid problem, or is it something like this? So
that depends, right? So that's another good segue to a topic. So, not getting like, kind of nerding out on the actual chemical structures of all these products. We have kind of 3 varieties of opioids. We have the naturally occurring opioids, which are basically kind of what comes from the poppy plant. So that's going to include things like your opium, that's going to include your heroin, and codeine and morphine kind of fit that. They look very similar if you actually look at their chemical structures with one another. Getting away from that a little bit, you can start to get to what we call like our semi-synthetic opioids. They start to have a less chemical sort of resemblance to the naturally occurring ones, and so that includes like your oxycodones and hydrocodones and whatnot. And then you have like fully synthetic ones that are just like, just entirely man-made, and they have no chemical resemblance to them, right? It's like fentanyls and your tramadols and things like that. So in terms of having an allergy between those, which ones do you think would have like a cross-reactivity? So if like a patient had like, say, a codeine allergy, they would very likely have what other allergy? Probably morphine, right? Because codeine turns into morphine. There's enough resemblance that your body could have that same reaction to it, right? Similar to like heroin, right? They look very similar. There's some cross-reactivity between, say, like morphine to hydrocodone because they still look a little bit like one another. However, with things like fentanyl and tramadol and buprenorphine and all those, they're fully synthetic. They're very unlikely to have a reaction to that, right? So it's very likely that they will not have any cross-reactivity because they just look so dissimilar to one another, to the body. So frequently, while patients will say, "Oh, I have a legit morphine allergy. I can't get Dilaudid. I can't get X, Y, and Z," and we can use fentanyl, and they have no problem with it, right? Because they don't share that sort of chemical structure. That makes sense. We'll talk about that a little bit more as we go on. Now, sometimes you have patients who will say, like, yeah, I'm allergic to morphine, and I'm allergic to hydrocodone and oxycodone, but like Dilaudid is the only thing that works for me. Sometimes, and I'm allergic to Toradol. Definitely can't get any of that Toradol. Dilaudid's the only thing that's good. The Dilaudid, that's it. So sometimes it's illegitimate, but in some cases it could be actually legit. They have some cross sensitivity there. But anyway, so again, keep in mind there's a distinction between the histamine release with morphine versus a true anaphylactic allergy. So then we have hydrocodone. This is very frequently going to be co-formulated with acetaminophen, either like Lortab or Norco. Usually you find it between like say 5, 7.5, 10 milligrams, and then usually with like 325 of acetaminophen. Very rarely do you find it by itself. There's one formulation called Zohydro ER. And again, when do you use like extended release products? You use it for like someone who has like an acute fracture. No, it's for chronic pain issues. And so if you think about like, a normal dose of hydrocodone be between like, 5 to 10 milligrams. I mean, you find formulations of hydrocodone by itself in the Zohydro of like 80 milligrams. Like it's just gobstopping amounts of hydrocodone. But again, when you get that tolerance, it's reasonable that you can actually work your way up to doses like that, right? So again, you'll find some very odd dosing, but if they've worked up to it over time, they can definitely have that kind of tolerance. So, and again, this is like frequently one of the most prescribed medications in the entire U.S. because it was just being used a lot in ERs and places just in acute pain. A lot of patients would be getting this filled here. And that was back when it was a C3. Now it's been bumped up to a C2. Again, a lot more restrictions on it. Hopefully, it's kind of curtailing a little bit of that. Now here you're going to find that it has also a little bit of variability in terms of its metabolism. It does get metabolized by CYP2D6 over to Hydromorphone, which is Dilaudid, which I'll mention here in just a moment. So again, if they have slow metabolizing CYP2D6, they may have less effects from hydrocodone. If they have a lot of CYP2D6 or ultra rapid metabolizing, then they'll have a lot of it converted over and it will work very well or too well in some cases, and you can see that toxicity there. So, but again, it's not going to be as sort of variable as you'll see with codeine, because codeine itself is not really that active, but the morphine is. Here, hydrocodone itself is a pretty good agonist at the mu receptor, so it has its own inherent sort of ability, right, activity. But yeah, you'll see definitely a lot of hydrocodone out there. Nowadays, it's starting to even out between hydrocodone and oxycodone because they're still kind of both clinically pretty similar to one another in terms of activity. And then, again, they're both C2s now, so there's not really a good reason to, give one versus the other. So then oxycodone, usually you'll either find it by itself. If you see like roxicodone, that's the drug by itself. Sometimes you'll find it in combination with acetaminophen. So if you see like a Percocet, remember that CET at the end, that means there's acetaminophen in it, right? So if you see Lorset, sometimes that'll be another hydrocodone acetaminophen product. And then you have the almighty OxyContin. So OxyContin is really interesting, and if you find this topic of like the opioid epidemic interesting at all, I urge you to check out. You guys ever watched Last Week Tonight with John Oliver?
Yeah.
So go on YouTube, you can find these videos. He has a couple of videos about OxyContin, the opioid crisis, and Purdue Pharma, who are the people that actually put out OxyContin. It's really, really fascinating. These are some pretty rotten people when you get down to it, from all we can actually tell. Just based off the kind of the human misery this actual drug is caused. But what it comes down to is that originally when they came out with OxyContin as this extended release product, and they said, yeah, it works great, you don't have to take it twice a day, works for 12 hours, it doesn't cause any addiction. Now, nowadays you would know that to be blatantly false, right? Any opioid can cause addiction, right? Because again, they're all working through the same receptors, they can all cause the same dopamine squirt, anyone could be susceptible to it, right? Also, they were really pushing the marketing and say it's Q12 hours, Q12 hours, Q12 hours. Well, it really doesn't work that long. In a lot of cases, towards the end of that, say 8-hour period, it starts to wear off, right? So patients were taking it, basically after the end of that 12-hour period, their pain was coming back, and so they were taking more than they should have, so they start to self-medicate to manage their pain. And so that was thought to also lead to a lot of that addiction that happened there. But their marketing was really strong in that. They would take all these, providers out for all these wonderful dinners and buy them golf clubs and all kinds of stuff in order to push for that Q12-hour dosing, and there's no addiction. It's totally safe. You can give it to anyone. It's totally fine. It's really not fine, right? So a lot of problems with OxyContin there, which you'll certainly see if you work, especially behavioral health, ERs, things like that, right? Anyway, this one actually does get metabolized as well through CYP2D6 to oxymorphone, so you'll see a little bit of variability there, but again, it's difficult to determine who's going to have a problem. Next we have Hydromorphone or Dilaudid. This one is good. We would find a lot of patients who had, say, significant itching with, say, IV morphine. They did respond pretty well to IV hydromorphone, but certainly you see some patients will be managed orally on hydromorphone as well. I see a lot of sickle cell patients that do well with Dilaudid for chronic dosing for their pain issues. There are some hepatic metabolites that can cause some problems. For instance, like the 3-glucuronide causes some myoclonus, but again, clinically it doesn't come up too frequently. This one I'm starting to see more and more use of, especially like in say for instance like the post-surgical setting. I do see a lot of Dilaudid being used, say like in the PACU. Anyone know what PACU means? post-anesthesia care unit, right? So they just come out of surgery, they're having acute pain. See a lot of Dilaudid being used because, again, it's a fairly short half-life. So again, if you're treating those really kind of acute pain things, like using a short half-life drug can be pretty reasonable there. So you'll definitely see a lot of hydromorphone use out there in the hospital for sure. And then we have fentanyl. Fentanyl is really kind of an interesting drug itself. Fentanyl is extremely potent, right? So 100 times more potent than morphine. So what's like a normal dose for morphine, do you think, like an adult patient? 2 to 4 or 5 milligrams, right, is a pretty good dose for morphine for an adult. That's an IV dose of morphine for patients. An equivalent dose of fentanyl is between 50 to 100 micrograms, right? So it's an extremely potent drug. You have to be really careful with the dosing and don't accidentally say, I'm going to give this patient 2 milligrams of fentanyl because they will be dead, right? Way too much drug. But this is a fully synthetic one. So if you did have patients with an allergy to, say, the hydrocodone, oxycodone, morphine, they could receive fentanyl with little to no risk for having cross-reactivity there. So that's one benefit there. And we do use it quite frequently for like in the surgical setting, but I'm starting to see much more use outside of that. So for instance, we use it in the ER quite frequently. And there's a lot of different dosage forms you can use too. So for instance, you can use the IV, which you see a lot in the surgical realm, but we can do it intranasally. So if we have a kid who comes in to the ER and they don't have an IV yet, but they need opioid pain medication, well, what's faster than oral without using an IV? Well, we can actually give it intranasally. So we'll just use an atomizer, and that one, nasal mucosa will absorb it, and it works pretty well from that standpoint. Not as fast as IV, but still works pretty well. There's transdermal formulations. So for instance, there's like the Duragesic patch, which you'll see for chronic pain use. One thing to keep in mind with that, how fast do transdermal products kick in? Pretty fast, pretty slow? Pretty slow, yeah. So those are more for chronic issues. And sometimes what we would do is if you had a patient, say, on a fentanyl drip, you'll see a lot of times for patients who are intubated and sedated, they'll be on a fentanyl Versed drip typically. What type of drug is Versed? It's anti-epileptic. What class does it fall into? The benzo. What's the generic?
It's the weird one.
Midazolam, yeah, so midazolam. So if a patient's intubated and sedated, they're typically on a fentanyl and Versed drip. And fentanyl, sometimes what we'll do if they need to remain on chronic use, we want to wean them off of the IV, we'll actually put the patch on them the same time the IV is running, the drip is running, and then after, say, 12, 24 hours, we'll actually go half dose on the drip, and then we'll just wean it off completely, and then by that time, the patch is actually kicked in, usually after 24 hours or so. But not only that, we also have, interestingly, here's a transmucosal formulation, so we call this the fentanyl lollipop. And basically just kind of stick it right next to the cheek and you'll absorb it there, and it kind of allows you to use sort of as needed. If you need more pain relief, stick it in there. If you don't need as much pain relief, you take it out, right? Who might that be a problem for? Kids, they see a lollipop, they say, yes, that looks delicious. Let me try some of that. And then all that fentanyl comes right out. So not great. So you don't see that too frequently. But there's a couple of cousins to fentanyl. So my dad's a CRNA, and he's probably the biggest source of where I get most of my sense of humor, or lack thereof. And so we always talked about fentanyl and the fentanyl family. So we talked about Al, Remy, and Sue. So those are the three kind of congeners of fentanyl. Yes, not very funny. But so there's Al fentanyl, Sue fentanyl, and then Remy fentanyl. Remy, have your own drug named after you. Okay, I'll catch you up later. Anyway, so those you typically see a lot, like in the surgical setting. So for instance, like our cardiac anesthesiologists use a lot of like sufentanil. Some of our other anesthesiologists use remifentanil. You kind of get used to them as you work in that setting there. And again, pretty good for patients if they do have a true opioid allergy to something like morphine. This is totally reasonable to give to those patients there. The reason why this is a big problem nowadays, we're seeing a lot more deaths associated with fentanyl, and a lot of it is because most of the heroin that's out there is actually being laced with fentanyl. A lot of it's coming in from places like China, for instance, and they're starting to find that you can just basically place this into your doses of heroin, and you can basically get a lot more doses out of it. Say a kilogram of fentanyl than you would a kilogram of heroin, because it is so potent there, right? And some of the big problems we're having here is, if you were to buy drugs from a pharmacist, you would reasonably assume that the doses that labeled on there is the dose that is actually there, right? If you're buying fentanyl, or say you're buying heroin off the streets, how reasonably assured can you be of that dose? Very, like maybe you just know your dealer really well. It's like, listen, I know Johnny super well. He's always been good to me, but who knows where Johnny's getting it from, right? And so again, I don't know if any of your chemistry experiments ever went poorly, but say for instance they were trying to cut in the fentanyl into their heroin, and maybe they don't mix it very well. You can find these certain doses may have way too much fentanyl in them. than what they were planning for, and then that's where you see a lot of like very significant CNS respiratory depression, and these patients would die essentially, right? Or they would think it's a normal dose of heroin, not realizing they've been cut with fentanyl, and they just get way too much opioid effect. So they're starting to see a lot of fentanyl deaths here in Florida, and it's been mimicking the same rise in heroin deaths that we're seeing as well. So there's some good graphs from like the CDC and Department of Health you can check out for that. There's also some other derivatives too, things like carfentanil. If you ever hear of that, it's another congener of fentanyl that's going to be causing a lot of deaths here in Florida. Up next we have methadone. You guys cover methadone at all with that MAT training? They mentioned it there. We're starting to move away from methadone a little bit and using more buprenorphine. I'm sure they mentioned it somewhere in that training, right? Okay. I see some people who are like, yeah, but no one else just ever did it. So anyway, you'll see it there. But methadone is kind of interesting. Methadone got its main use for a long time in terms of being used to wean patients off of their opioid addictions, right? And so there's a couple of reasons why that is. And so it does act at the mu receptor. It has some other kind of ancillary effects, which may or may not kind of help out with its clinical effects there, but it has some NMDA receptor antagonism, some effects on serotonin and norepinephrine. But the main reason why we liked it is a really long half-life. So like 50 plus hours this drug would stick around for. So what do you think would be good in order to help patients wean them off of opioid addictions? So, because the patients are, let's say they're addicted, they're physically dependent on an opioid. Why is using something with a really long half-life be useful? Mainly because it helps to prevent withdrawal symptoms, right? So, for instance, and this is, you guys ever heard of like the methadone clinic before? I'm sure most of you have like heard that term before. And basically, what would happen is your methadone clinic's only open Monday through Friday, and so you've had people who come in, they get a dose on Monday, Tuesday, Wednesday, Thursday, Friday, and all that time they've been kind of dose stacking up to where they have a pretty good level, right? So, and again, how long does it take to get to that steady state? 4 to 5 half-lives. Fentanyl 50 plus hours, that's going to take a long time, right? But say they get a decently high dose on Friday, methadone clinic closed on the weekend, you find that hopefully they're not going to be abusing any other opioids, but the idea is that their levels are high, they would gradually decline over the weekend, hopefully not have any withdrawal symptoms, and by the time Monday morning rolls around, and again, Monday morning at the methadone clinic is hopping, let me tell you what, you come in, get your next dose, and then you're good to go, right? So the idea is hopefully you're not going to be abusing any other opioids during that time, but again, you're hopefully not having withdrawal symptoms.
Is it true that these clinics allow pregnant women to go there so that they're not
I don't know a ton about regulations in terms of like any with pregnancy status and stuff. I mean, certainly there would be some benefits to using methadone over, say, for instance, like IV drug use, certainly communicable diseases. You never know what the stuff is actually laced with. I mean, there's a lot of other safety features that go into that, but I don't know about that specifically. So, but it's a good question. So anyway, so that was kind of the big thing there, is it provides nice long-acting relief. However, though, we do use it for other reasons. So for instance, if we do have, say, a newborn who has neonatal abstinence syndrome, we do use clonidine for them in some cases there because it does provide nice long-acting relief and prevents those withdrawal symptoms. So again, you just kind of gradually wean them off. And again, you're responding to them based off their vital signs and if they're fussy or not. And then you're kind of seeing how they respond from that standpoint. But nowadays we're starting to use it a lot more frequently for chronic pain issues because again, it still has that nice benefit of having a long half-life. Levels stay pretty consistently there, so it's not uncommon. You may see a patient who's on methadone, say once daily for chronic pain, and then they may be on like an as-needed, say oxycodone for breakthrough pain or something like that. So that's becoming more frequently seen there. I am starting to see more people kind of moving away from methadone and over to buprenorphine, which we'll mention why that is in just a few minutes here. But anyway, other things to note here is that it does cause QT prolongation, so you do want to be cautious with that. Certainly, if I had a patient who overdosed on methadone, I would be very concerned about that, check an EKG, but if they're on multiple medications, obviously they can prolong that, then we know what risks are associated with that, right? And again, a lot of problems, especially with like converting patients from their methadone dose over to like inpatient IV opioids. I mean, there's all kinds of problems with using methadone. It's a pretty tricky drug in a lot of cases there. You always want to be really careful when you're doing like a med rec or med history on a patient and they tell you their methadone dose. Kind of a rule of thumb I've heard some people use is like, you always double their, whatever they tell you they drink, and then you always half what they tell you their methadone is, their dose is. And I'll give you an example of why that is. At one hospital where a patient had come in, they're going to get admitted, they're on methadone for opioid use, and basically they lied about the dose that they were receiving. They gave a pretty high dose, but it wasn't something that was like completely out of the ordinary for someone who'd been on it for a while. And so they ended up, basically the pharmacy tech who's doing the med rec then communicated that dose over to the pharmacist who didn't check. The pharmacist put it into the chart, said, okay, this looks good, and then the provider who's admitting said, okay, it looks good, let's continue it. So what do you think happened to the patient? Well, they got this really big dose that they weren't used to, and they were basically found the next morning completely zonked out, had to give them the rescue medication, right, is a big problem, right? So again, if you call and you double check on these things, E-Force can help out with that too. That helps to hopefully limit kind of situations like that. So always be careful when it comes to things like that. Okay, next we have a drug called Meperidine or Demerol. I had a pain management pharmacist in school who called this stuff Demonol. She really did not like Demerol, and its use has kind of gone down quite a bit because of a lot of the problems with Meperidine. Big issues with it for patients who are using it chronically is that due to renal insufficiency, they would kind of build up these metabolites, things like normeperidine, and that would cause CNS excitation all the way up to causing seizures, and cause like tremors, myoclonus, all kinds of like neurologic findings there. And so because of that, they stopped using it for more chronic issues. The one place you will see it used with some regularity will be on the inpatient side, and either in, like say in the ER or say like in the surgical setting, and it's mainly going to be used for rigors. You know what rigors is? They're shivering, right? So for instance, like in the ER, if you have a patient who say you're doing a therapeutic hypothermia, where you want to lower their temperature, maybe they had a stroke or heart attack or something like that, you want to cool them down to try to preserve as much tissue as you can, right? And so what happens when your body gets cold? You start to shiver, right? And so that raises body temperature. So to prevent that, we'll actually give them Meperidine to stop those rigors from occurring. Or sometimes post-anesthesia, they may get those rigors as well. So sometimes you'll see some doses of Meperidine being used for that. And that's a very specific indication. I probably would never use this for acute pain or anything like that because of the issues we see with this. Cardiac toxicity can occur. I mean, just not a really good drug from a lot of those standpoints there, right? I had another point to make with that, but now I forgot what it was altogether. Must have not been that important. And I hope it's not in the test. Just kidding, probably won't be. Okay, next we have Buprenorphine, or Suboxone, or Subutex. Now this one I'm pretty sure you have heard of in your MAT training. Yes, all right, see more head shaking, that's good. This is another long-acting opioid medication. This one you won't see being used for chronic pain like you would with Methadone, mainly because it's a partial agonist, okay? And it has a really high affinity for the mu receptor. So what do you think would be the benefit of using a partial agonist for opioid addiction for these patients here? So you may not get as strong of an effect out of it, right? If I have a patient who's taking methadone, say they're on the weekend, methadone clinic is closed, they decide to take some heroin. Methadone on top of heroin, you're just going to get more effects, right? What if I use heroin on top of buprenorphine? It's going to be, the buprenorphine is occupying those receptors, and they bind so tight to it that it actually prevents other drugs from coming in and kicking it off and having their full effects, right? And so, again, it's a competitive inhibition, right? So you can overcome that. You can do enough heroin to overcome that effect, but it's harder to do, right? And so what we end up seeing is that by using this, you can have a patient on something to where they will have enough activity to hopefully hold off withdrawal symptoms, but they're not going to have so much to where, and again, they have a drug that kind of prevents other things from acting fully at those receptors. So, the thing you have to be careful though is you have to tell patients before they start this drug, what do you tell them? You can't be using any other opioids, right? Because what would happen to someone who is chronically using opioids and then you give them a dose of buprenorphine? It's going to kick all that other opioid off the receptor, and then buprenorphine's only just sitting there kind of partially activating it. What happens? They go into withdrawal, pretty significant withdrawal. Actually, I had one time I had a patient who's coming into the ER, EMS, sometimes we'll call in, what's going to be coming in. They say, we got this 40-some-odd-year-old lady. She overdosed on buprenorphine. We'll be there in 2 minutes, right? And so in my mind, you get a picture of, okay, what's that patient going to look like? And if I had assumed what a buprenorphine overdose would look like, you would say what? Would they be like awake and talking? No, they'd be probably near getting intubated because they're so sedate and CNS depressed, right? So this lady comes in and she is restrained, 4-point restraint. She's biting, kicking, spitting at everyone, screaming at the top of her head, causing a complete scene in the ER. And I was like, boy, that does not look like a buprenorphine overdose. However, it actually was. We had to give her some Ativan to try to calm her down. Once she was a little more calm, we were able to get some history out of her. And what actually had happened was that she was normally taking methadone. She ran out for whatever reason, and then so she decided to take her friends buprenorphine, not knowing that by taking that buprenorphine, it would come along, kick all that methadone off the receptor, and she basically put herself into withdrawal. Right? So even though it was an overdose, she's actually getting much less opioid effect than what she was used to getting. Okay, so that's why she was presenting that way. So you have to be really careful with that. And in fact, if you have a patient who's, say, going into, say, a rehabilitation program, they have to tell them that don't take any opioids before you come in, because you want to make sure you start the buprenorphine once they start having mild withdrawal symptoms. So that way the buprenorphine will prevent those, kind of ameliorate those, and then they can kind of continue on. For instance, we had some patients who had the same kind of effect happen with the implant. Basically, you tell them, okay, don't do any opioids before we put this implant in, because if you do, you're gonna have a bad time. And so I say, okay, I'm not gonna do it. They did the procedure. Say, have you done any opioids recently? And they said, nope. They were lying. Got the implant put in, and they go into withdrawal. Right? So very difficult to manage, because again, once the drug's there, it's there. Once it's absorbed, and so it can be pretty problematic from that situation. So anyway, so that's the main use you're going to see with that. This can be really nasty, especially in kids too, because again, even a single, like an 8 milligram dose of buprenorphine, I've seen some kids be, knocked out basically for 2 days in the ICU. So pretty significant from that standpoint. Now you will see Suboxone either by itself or co-formulated with naloxone. And what's naloxone? It's Narcan. What does it do? It's an opioid antagonist. So we'll talk more about that in detail in just a little bit. But basically, they co-formulate with naloxone. Now, naloxone orally does not have any bioavailability. It does not work at all. So why would I co-formulate buprenorphine plus naloxone in an oral formulation? What if someone tried to inject the buprenorphine? Right? Patients will take these prescription products that are meant to be taken orally. They will solubilize them, try to get the drug out, and then try to inject them in some cases. And so the idea here was by a co-formulate with a naloxone, they inject the buprenorphine, the naloxone would then just kick it off the receptor, and then they wouldn't get any high from it. Okay, so sometimes you'll see that combination. That's specifically what is meant to deter there. Okay. So in general, those are the main opioids you're going to run into. How you pick the ones you're going to pick are going to be based off of things like the pain intensity that they're experiencing, right? So they're coming in, they're complaining of 9 out of 10 pain. You're probably not going to give them a dose of codeine, right? Probably not going to be too happy about that. But something like IV dose of fentanyl, morphine, Dilaudid, all those are really good from that standpoint. Look at other coexisting conditions, look at the economic factors that's going into this. And for the most part, if they're having chronic persistent pain, they'll typically be on a long-acting, something like an Oxycontin or an MS Contin, say once, twice a day to cover them throughout the day, and then they'll usually be on an as-needed, immediate-release acting drug, just to cover the breakthrough pain periods there, right? And then generally, we'll use oral for most of our dosing, especially on the outpatient side of things, and then we'll occasionally use transdermal, especially transdermal fentanyl is the most common one. That one is, again, not for acute pain, because again, slow in onset of action, but once it's there, then it works for a long period of time. Another thing to be really careful with fentanyl patches, a good education point for your patients, is to make sure they never apply heat to it, right? And again, patients like, say, chronic low back pain, what is sometimes they use as a non-pharmacologic therapy? They use heat, right? Well, actually what happens when you apply heat to a fentanyl patch, guess what happens? You expedite the release of that drug into the system. Patients have died before by accidentally releasing all that drug at one time. So be very careful with that. Make sure they're not applying heat to it. Make sure they're not going to get into the jacuzzi with their fentanyl patch on. See some patients die because of that, basically drowned because they got knocked out from the fentanyl. Not great. Other things to consider too is like whenever you have a patient who's coming in and you suspect they could have an opioid overdose, but they don't have anything on their profile, you got to do a head-to-toe exam, right? You got to strip them down to make sure they don't have any patches that are there, because I've had some cases where the patch was missed and the patient was having these like kind of protracted effects and they just couldn't figure out why, and it's because he still had drug that was releasing into the system, right? So you got to be careful with those patches there. Okay. Anyway, in general though, you'll find that these therapies are going to be very individualized. I mean, for instance, my wife did a whole year of just pain management to become an expert in it. People go through entire fellowships and training. So again, it's difficult to be an expert at this stuff. But again, you're going to be expected to treat a lot of patients for acute and chronic pain. So in general, start low and go slow, right? You can always give more drug if you need to. It's really hard to take it back once you've already given it, okay? Let's do a 10-minute break. We'll come back and then we'll see if we can finish out this section. Let's see if there's any questions. How is buprenorphine compared to other abused opioids? Is it addictive? Does it give you those opioid effects? Are there other uses for it besides addiction? So is it addictive? What do you think? Potentially, right? It's still acting on the mu receptor, so it's a possibility, right? A lot of patients are not going to get started on this unless they usually have a history of opioid abuse disorder, right? So it's not really used for anything else. Like, whereas methadone, being a full agonist, you can still get some benefits from that in terms of like chronic pain management. That's not how it was used originally, but that's how its use has kind of evolved over time. Buprenorphine is really strictly just for opioid abuse disorders, right? In order to wean those patients off, to eventually use less and less, and then they just come off completely, right? It can still give you opioid effects. I mean, like, if you take enough of it, it can still give you some decent effects there. So it's all about the dose in a lot of cases. Would it be okay to use Demerol for chronic pancreatitis? So that was interesting. I think in some of your readings, it was probably stating that Meperidine was preferred. I don't know if there's any clinical evidence necessary to show that necessarily. There were some concerns, I think, with like morphine possibly causing some cholecystitis, as they kind of weaned away from that because they're kind of thinking, okay, GI tract stuff, maybe not morphine, but I typically will not see Meperidine being used for that. I would probably more likely see oxycodone or something. If I get a note that said Meperidine on there, I'm not going to falter for that necessarily, but it's just something that you're seeing less and less use of, right? So even though technically it could be correct, it's just clinically not done, right? All right, any other questions on that? Let's continue on. So one thing I will note, and I'm not going to get super in-depth on this or ask questions about necessarily doing in-depth conversions, but opioid conversions are important, especially when, say, for instance, you're admitting a patient into the hospital, or you're maybe getting them ready for discharge and you want to convert them, say, from IV doses of opioids over to oral doses. It's not an exact science. There's a little bit of art to it. And so you'll find that there's a lot of different ways to do that. Most hospitals will end up having an opioid conversion chart available to you, but the reason why we do this is because one, you want to make sure when converting from, say, an oral dose to an IV dose, you have to take into account the differences in potency of the drugs. You have to take into account what you have available to you, what the bioavailability, all the pharmacokinetics of it, and so it can be really tough. One of the things you always want to know is that whenever you're converting patients, say, from one type of opioid to another, or say going from IV to PO or vice versa, you do want to worry about something called incomplete cross tolerance, right? Basically what that means is that just because you convert, say, someone from an equivalent dose of morphine over to hydromorphone, they may have some variability in terms of how they respond to that hydromorphone, and they may actually get some exaggerated effects. And so because of that, we typically would kind of build in a safety margin with ourselves and maybe cut the dose down by convert it down to 75 or 50% of what the equivalent dose would be. The benefit of doing that is that, one, we may get, the risk is you have undertreatment of their pain, but the benefit is I can give some more if I need to, right? I don't accidentally over-sedate them because they have this incomplete cross-tolerance. You do want to be careful with that. The other thing to note is, as well, is that you want to factor in all the doses of the medications they're getting, so take into account their extended release drugs, take into account the average times they use their breakthrough as needed medications in order to kind of come up with what their daily dose should be. Here's an example of an opioid conversion chart to kind of give you some ideas of, equivalent doses. I'm not going to ask you specifically, okay, what's an equivalent dose of 4 milligrams of IV morphine to oral hydromorphone? I'm not going to do that to you, right? But know that there is a conversion into that. Know that there are differences in potencies, and that it's important that you actually take this into account when you're dealing with these patients, right? And so you always want to make sure you're double checking your math. Pharmacists can definitely be a big help with you if you have that resource available to you to kind of walk you through the process as well, right? And so just to give an example, you can refer back to that. Let's say we had a case where you had a patient who is, say they had lung cancer, they were terminally ill, very painful type of cancer, and let's say they were getting Oxycontin 40 milligrams every 8 hours, right? Again, Oxycontins are extended release oxycodone, and they want to convert it over to parenteral hydromorphone as say he's coming into the hospital. Okay, so now we have to take into account we're going from an oral dose to an IV dose, right? And typically, which one do you think is more potent, IV or oral? Probably IV, right? Because bioavailability is 100%, right? We're also going from oxycodone over to hydromorphone, right? So again, there could be some changes in potency there as well. The first thing you always want to do is figure out their total daily amount of opioids they're getting. So in this case here, because they're getting 3 doses a day, ends up being that 40 milligrams times 3 administrations, 120 milligrams of oral oxycodone per day that they're getting, right? And then what we can do, kind of a common step they always do, is convert everything back over to oral morphine equivalents, right? It's kind of like your home base in terms of opioid conversion. So you convert it back to oral morphine equivalents, and oral oxycodone is roughly 1.5 times more potent than oral morphine, okay? So basically, you just multiply their oxycodone dose by 1.5, and you get from 120 over to 180. So again, if I don't want to do it at that point, I can convert that patient over from OxyContin over to MS Contin, and I basically put them on 180 milligrams of morphine a day. Probably cut it down a little bit for that cross tolerance, but you could do that, and that'd be an equivalent dose, right? Now, the last step is I want to convert it over to my end product, right? So in this case here, it's parenteral hydromorphone, and so we find that IV hydromorphone is 10 times more potent than oral morphine. So then I would say 180 milligrams per day divided by 10. I know that their total equivalent dose of hydromorphone a day IV would be 18 milligrams. Okay, now then you can then divide that up, right? So you could either do it via continuous infusion, right? So then I would say 18 milligrams divided by 24, so I can actually get an hourly rate that it would be getting continuously. I could do it intermittently, maybe every 4 hours or 6 hours, whatever the case may be, but in total it'd be about 18 milligrams. Now again, I would cut down on that a little bit. Maybe I'd start with say either 9, maybe 10 milligrams, maybe 14, somewhere around there, right, to account for that cross tolerance, and then I can go up if I need to. Does that make some sense?
Yes.
So again, I'm not going to have you do this type of conversion on the test, but I want you to at least be aware of sort of the process and make sure that you know that this is something you have to take into account whenever you're switching these patients' stuff around, right? For these chronic pain patients.
So would you start them off around like 12 milligrams?
Yeah, somewhere around there. And again, there's no like absolutely right or wrong answer. And in fact, as I mentioned, my wife who does this, professionally, sometimes for one patient, you'd be like, maybe 10. For this other patient, maybe 12. You just kind of figure out like what's their pain like right now. Are they more severe? Maybe I bump them up a little more, right? Maybe if they're not in so much pain, I'll bump them down a little bit less. There's a lot of art to it, right? In terms of medicine, more so than students like, because students like correct answers, they like right answers. There's not always going to be one right answer to a lot of these situations. Nicole asked, well, if your wife's an expert, why didn't she give us this talk? I said, that would be a great idea. She's actually much more well-versed on this stuff than I am. Unfortunately, she hates public speaking and would refuse to do it. I've asked her before, I said, you want to come in and do it? And she's like, never. Some people have no shame and they don't mind hearing themselves talk for hours on end, and so they even build these edifices of YouTube channels for other people to even listen to them, and a lot of narcissism that goes around for your faculty. But anyway, getting into PCAs. What's a PCA? Ever heard of that? The patient-controlled analgesia. So basically they have an infusion set up to where it's running IV, and they have a little button they compress to give themselves a demand dose. What do you think is the benefit of doing that?
Controls like spikes of pain.
Yep, so it'd be good for like breakthrough episodes of pain.
In our patients, they would call like every 10 minutes too, so it gives them a little bit, gives us more free time to kind of manage other patients while they're being treated.
Yeah, so maybe like the nurse doesn't have to come and respond every time the patient's calling out for pain. They can kind of control that themselves. And in fact, if you look at overall opioid use between someone who has like say an as-needed order, kind of like what you're writing for your prescription assignments, versus a PCA, overall you find that when patients have control over their own analgesia, that they overall use less opioids. So that's another benefit you'll see with a lot of that, is that overall they are using fewer opioids, which is always a good thing. It's going to get them discharged faster in a lot of cases. It's important to know the sort of core components of a PCA order, because you're going to see these, especially when you're doing like your surgery rotations and things like that. We like to use these in the post-surgical setting in a lot of cases. Basically, there's 4 components you're going to see to it. The 3 most important ones are, one's going to be the basal rate. I say basal rate, what does that mean? It's like when you're cooking spaghetti, you have like a basal rate of how much you're putting on there. No, it's basically how much they're getting sort of continuously, right? So what are they getting at baseline, okay? I'll show you an example of an order here in just a little bit, but that would be usually in terms of like milligrams per hour, okay? They're gonna get that continuously around the clock. That's for their basal amount of pain they're experiencing, a basal rate. They will then have an on-demand dose, which means that's kind of their as needed. That's when they press the button, what they're going to actually get administered to them. And then there's what they have is called a lockout interval. Anyone know what that means? Yeah, so you just can't sit there and press the button 500 times to get 500 doses, right? Like it would not get to 500 at that point, right? You'd be so knocked out. But it provides a period of time where they cannot get another dose. Now, what's nice is those pumps will actually still count every time they press that button, right? So for instance, if it's set to every 15 minutes for them to get a dose, but they're pressing it every 10, what do you think that means? They need more, right? Their pain's not being well controlled here. Now, in pediatrics, sometimes, kids are bored and they're, they're good on TV, so they'll sit there and just click it away, 500 times, and you're like, okay, well, they're probably not really that much pain, they could be bored, right? So they may not always be legitimate, but in some cases you could get a good idea of, okay, well, their pain's probably not controlled, maybe I need to bump up some of these doses here. So for example, here you see like a morphine IV PCA, we do a basal rate of 1 milligram per hour. They'd have a demand dose of 0.5 milligrams every 15 minutes. Right, so they can get a total of 4 doses in an hour of that 0.5 milligrams, okay? And we'll usually actually put a fourth thing on there. It's they usually have like a 4-hour dose limit. I don't know why they picked 4 hours, it's just what they do. And you basically add up all together what they could get at a maximum, and then put that as your 4-hour limit. And that allows the nurse to program everything in, make sure it all makes sense from that standpoint. Here's an example of what one would look like. It's a little grainy, but here's like the medication here in the syringe. Usually that's locked, right? Because I don't want people to accidentally access that and run away with it or something. And then here's like the button the patient will be able to press themselves, okay? Now, what do you think are some limitations to this? Who might not be a good candidate for a PCA? An addict? Well, not necessarily, because again, they are somewhat limited in some ways, right? There's usually a code associated with these, so that way when the nurse walks away, the patient can't just go program in whatever they want, right? If they can't push the button, maybe they're too sedate, or what if you have like a 2-year-old? Not going to be with it to do that, right? So again, the patient has to understand how to actually administer this themselves. And again, you don't want the family to be in control of this at all either, because usually families are going to be what? Oh my gosh, I want to make sure they have no pain whatsoever. You got to make sure you're pressing that button, right? I don't want my kid to be in pain. Give them some more drug, right? That's not great either. You want the patient to be the one actually pressing the dose themselves, and so they need to kind of be with it enough to actually make that decision and be able to actually press that button there, okay? And as I mentioned, that 4-hour limit's usually going to be one of those other components there. Again, to get that 4-hour limit, you're just adding up their basal rate for that entire 4 hours, and then every single demand dose they could get, that gets factored into that. So for instance, if they were getting that 1 milligram per hour in the 15-minute 0.5 milligram demand dose, you just add it all up together, you get roughly 12 milligrams as your 4-hour max, right? So that's the max amount they can get over that 4-hour period, okay? Yeah, and that sometimes that'll come about from the specific setting there, and hospital policy dictates a lot of that stuff. So for instance, for our hospital, we say if the patient's not able to do it themselves, like we do not allow the family to do it, right? So you may find some differences in practice depending on kind of what the setting you're in, but yeah, so you'll find some variability there. Again, always follow your hospital policies. This is the best way to keep yourself out of trouble, right? If you ever have a question, be like, is there a policy for that? Let me look that up. But anyway, so what would happen if you came back and like the patient's like pressing the button like every 5 minutes? Like what could you change on this order here to maybe give them better pain control? So I could either go up on the basal rate potentially. What else could I do? I could decrease the lockout, maybe to change it every 10 minutes or so. What else? Or I could bump up the demand dose, right? So there's different ways you can do it. Usually the basal rates, the thing will kind of change. We'll figure out if we think they're legitimately having pain, we'll kind of figure out how much they were pressing the button, and we'll basically kind of add that additional amount to their basal rate to kind of bump that up a little bit. And hopefully, ideally, if their pain's well controlled, then they shouldn't be hitting the button at all, and then you can kind of decrease on the basal rate until they can wean off of it completely, right?
The providers I work with that work with people that had a lot of pain, they said that if it's working, then they just want to increase the frequency. But if their pain isn't controlled, then you want to increase the dose. Like that's like the mentality of like. So I feel like that would probably help guide me as this. Mm-hmm. Is like, if the pain is controlled or not.
Exactly, yeah. And again, how often they're hitting the button kind of can dictate that to you. In addition to what the patient's actually telling you, right? Because you may have some stoic patients who are like, yep, I'm totally fine, but they're sitting there hitting that button like crazy. Versus some people are like, kind of wimpy, and they're like, oh my gosh, I'm in so much pain. Please give me more, but they're not really hitting the button that much, So it depends on how your patient's kind of expressing themselves. Again, for some pearls in terms of this, typically when you're looking at the dosing here, on-demand doses are usually about 1/4 to 1/3 of the basal rate in a lot of cases there, and that last one you see is about half. So that can range certainly. And again, you can adjust it based on the actual use by the patient. That will be recorded on the actual pump itself, and the nurse will be able to document that in the chart usually. So in terms of adverse effects, okay, so in terms of opioid adverse effects, what are the really big things I'm worried about? What could kill the patient? Respiratory depression. and CNS depression, right? So again, imagine if they take some opioids and get behind the wheel of a car, right? They're going to be intoxicated. They could get into a wreck, right? They can syncopize and they can just stop breathing. Remember, this is kind of shutting down your brain's ability to detect that increased CO2, right? What's a more powerful driver of respiration, low O2 or high CO2? High CO2, right? I'll never forget this. The best illustration I ever saw of this was a game that the ER residents used to play when I was in fellowship. It was a game called DSAT. I've never heard of this. Basically, they were bored overnight. They didn't have enough patients to fill up their time, and ER residents are kind of like, I don't know, they have a certain personality about them. You may figure this out. But and so they decided to play this game called DSAT, where they basically put themselves on, put a pulse ox on their finger, and they'd hold their breath, and they'd see who could get the lowest pulse ox before they had to take a breath. It was interesting. It was really difficult to get down below like 98, 97% because the CO2 that was building up was a much stronger driver of respiration for them. So again, they'd eventually give into that before they would from the hypoxia, right? So again, a dumb way to illustrate a point, but I think it was a powerful thing that stuck in my mind at least, and may stick in yours. So again, they will, and sometimes we actually use that for our benefit, right? So sometimes we'll have these like end-stage COPD patients who are like, terminally ill, and they're just so air hungry. They're just so like, they have such high CO2 levels. They're so uncomfortable. We'll give them a little bit of morphine, and that will actually help to relieve a lot of that CO2 stress, and that way they're actually more comfortable. Even though we're kind of causing some respiratory depression, they feel better in those cases there. But, and so CNS respiratory depression. What's the other like classic like triad, part of a triad you would see with like an opioid overdose? Not with that overdose, you see that with chronic use for sure. They talk about pinpoint pupils as kind of the third part of that. So CNS, respiratory depression, and pinpoint pupils. Keep in mind that doesn't always happen. There's several opioids that won't actually cause that, so just be aware that's not always going to be the case, okay? In terms of other more frequent side effects, you're going to see constipation, sedation, certainly, nausea, vomiting can happen pretty commonly. Almost everyone's going to get constipated, right? Less frequently, they're going to see that, especially with normal therapeutic doses, respiratory depression should not be an issue, but certainly if you combine multiple CNS depressants together, that risk is going to go up. Or for instance, if someone's taking an opioid and they start drinking, that's going to be very synergistic with one another, so you have to be really careful with that. And also be considering things about abuse and diversion, right? When I say diversion, what does that mean? It's like, hey, look over there. Didn't work, bad diversion. Diversion is typically when people are either stealing or maybe trying to use medications when they don't really have a legitimate use to, or maybe to sell them, things like that. So for instance, this is something that's a big concern in terms of like healthcare providers, right? Are we magically immune to addiction because we have all this knowledge and healthcare experience? Absolutely not, right? So sometimes patients or healthcare providers using it themselves in order to get that high, or in some cases we may be trying to divert it to sell it, okay? Does anyone know what provider in the hospital is most likely to be abusing the opioids themselves? Anesthesia is actually going to be the biggest department for that, right? Who's most likely to sell them? I wouldn't, but in general, they see that the pharmacy people are, which is why we have so many checks and balances on making sure, like when you're wasting drugs, that you're double verifying that. So you have like a witness with you that verifies waste. When we receive drugs, we make sure that we have at least 2 pharmacists who are checking everything in to make sure the numbers all match up. So we do a lot of monitoring for this, and it's a big deal. But we look for also like behavioral things. So for instance, we have it's called a Pyxis machine. That's the brand that we have, where nurses will go get their medications. If you have like one nurse who's always getting the morphine for people, be like, hey, you go take your lunch break, I'm gonna get that morphine for that patient, right? And they have like really high use. That is something that could trigger off, our alerts to be like, maybe we need to look more into this, right? Or for instance, like, my dad, as I mentioned, he's a CRNA. He used to have a habit of drawing up medications to have on hand just in case, which now that I realize I'm a pharmacist, I'm like, why would you do that? Jeez. But he always liked to have it on just in case, right? And so they looked at his actual waste and his use. They found that it was a lot higher than everyone else. And so they were actually like, I had to drug test him one time, right? Came back negative because he was doing his job correctly, not diverting anything, at least to my knowledge. But anyway, he was, certainly flagged for that. And that was the thing, because he was kind of using medications outside of what the normal was. So diversion is a really important thing. And again, depending on your setting and how you're using these medications, you may be at risk as well, right? To minimize our adverse effects, again, make sure you're titrating these doses gradually. Again, start low and go slow is a general rule for a lot of these things, unless they have really obvious severe pain, right? And again, treat the adverse effects as they pop up. Sometimes, patients may not respond really well to one opioid, and you can switch to a completely another one, right? If they don't respond well to hydrocodone, try switching to oxycodone, or Hydromorphone or Fentanyl or something like that to see how they respond better to it, right? A lot of side effects they will develop tolerance to, so the sedation, things like that, they'll become tolerant to after a few days though, but the constipation is going to be constant, right? They're always going to be constipated. And again, we like to go with a sort of dual drug regimen here. So I mentioned the mush and push before. Have I said that before?
Yes.
All right, so what is the mush?
Stool softener.
Stool softener like?
Colace.
Colace or Docusate's a good one, right? And then the push is?
Stimulant.
Stimulant laxative like?
Miralax.
Well, that's osmotic laxative. Miralax is osmotic, right? Bisacodal or Senna was the other big one, right? Maybe good information to know for Monday. I had to guess, right? So, no, right? No, don't worry about that stuff, no. Anyway, so again, it's going to be very common. Certainly, you want to encourage them to get lots of fiber in their diet, make sure they're getting lots of fluid. But again, they're going to need some extra help with that. And a lot of times, like especially my wife was talking about some of these patients here who would be in-house, and you just could not get their pain under control. Like their vital signs are always out of whack. They always looked uncomfortable. And a lot of times, it was just the fact they hadn't stooled in a couple of days, right? Once they got their bowel under control, then they were able to find they were much more comfortable. Vital signs came down. They looked a lot better. They're much more comfortable. They didn't need more opioids. They need less, if anything, because they're so constipated. So be really careful with that. Now getting to the antagonists real quick. So naloxone is probably going to be the most common one you're going to run into here. There's been a lot of push recently to get more access to naloxone. So for instance, the Florida Surgeon General a couple years ago basically put out a blanket order saying that any first responder can go to a pharmacy and pick up a dose of naloxone in case they find someone who is overdosed on an opioid. Because if I overdose on an opioid, can I give myself naloxone? No, I'm passed out. I can't do that. It has to be an onlooker, right? And so who can be a first responder? Anybody can, right? So you could go right now to a pharmacy, to a CVS, and say, hey, I'd like some naloxone, and they can give it to you. They can sell it to you, right? Usually it'll either be like an intranasal kit they'll give you, where it's actually the IV form along with a syringe and an atomizer, or there may be an actual nasal spray they can use that's like formulated just like that. And then here's actually an example of an auto injector, and this thing's actually kind of neat because it actually will talk to you. So it's like an EpiPen, but it has all kinds of voice commands. So even if you had no idea what you're doing, it says, okay, place this on outer thigh. Hold down the button, 1, 2, 3, go through the whole process there. The biggest thing to make note of though is that, when you give naloxone, how fast does it work? Anyone ever seen someone get naloxone before?
Yeah.
It is,
Right?
if you give a pretty good dose, it is dramatic. And in fact, there's a movie called Bringing Out the Dead. I think it has Nicolas Cage in it. There's a scene, I encourage you to YouTube, I don't know why I use that as a verb, but to look up. Hello, fellow kids. I encourage you to look that up. But it's a Narcan scene where basically a guy had overdosed on heroin, and they basically have a religious revival. Meanwhile, the other guys, like giving the paramedics respond, they give the guy a Narcan, he wakes up quite dramatically. And as I mentioned, it can be like The Exorcist, because the risk here is you put him into what? Withdrawal, right? Because this is an antagonist. It's going to knock all the opioids right off the receptor there. So a lot of different dosage forms we have available. Most often either IV, intranasal tend to be the most common. We're going to be giving to these patients here. And actually nowadays we actually have more police officers actually carrying naloxone, right? Because when you call 911, who are typically the first people to respond? Could be paramedics, or a lot of times it's actually going to be the police that are responding first. And if they can at least get there and get a dose of naloxone on board, wake the person up, that can hopefully stave off a death potentially. The biggest thing that you have to be careful of is that, especially if it's like, say, a family member or a friend or someone like that who's administering it, you have to make sure that after they give a dose and they wake the patient up, what do? Call 911. Because they may falsely think that, hey, this patient looks good, I don't have to do anything, they're awake, everything's great. But what happens after about 30 minutes or so? They resedate. Naloxone does not work for very long, 20, 30 minutes or so. So they can't resedate, so we make sure they educate them to definitely call 911 in those cases there. Anyway, so naloxone, very good drug, works very quickly. Be careful though not to accidentally give too much, because your nurses will hate you. Because those patients are going to wake up, they're going to be cranky, they're going to be having diarrhea, they're going to be throwing up. It's not great, right? And in fact, if you dose it just right, best thing you can see is the patient will remain asleep, but they'll start yawning, right? Kind of wake up the brainstem that starts to detect all that CO2, and it'll start to breathe it off, right? And so again, you don't need your patient to be awake. You just need them to be breathing. So that can be an important distinction. You guys ever heard of a code brown being called in the hospital before? You know what that is?
We may happen to know what that means.
Yeah, when you give too much naloxone, you can induce a code brown, have to get environmental services to come out. It's not great, right? So be very careful giving too much naloxone to someone who's chronically on it. Now, if I give it to, like, say, a kid got into a dose of buprenorphine, and I gave them Narcan, would anything adverse happen? They're not on it normally. They wake up, everything is fine, right? There's no big side effects to worry about with naloxone. It's just with patients chronically on opioids, they can have those withdrawal symptoms. That's the biggest concern there, okay? There's a couple of agents that are sort of chemically related to naloxone, but these are just used, especially for like postoperative ileus or opioid-induced constipation. Includes things like alvimipam, methyl naltrexone, and then naloxegol. These are interesting because they don't actually cross the blood-brain barrier. So when you give them, they only work on the GI tract peripherally, but centrally they don't do anything to cause those withdrawal symptoms. So that can be useful to kind of wake the guts up and allow them to, again, start stooling normally and hopefully get them discharged or relieve that constipation there. So, any questions on opioids? So kind of moving into adjuvants and other medications, there certainly, when dealing with neuropathic pain, you have to think about other modalities, right? So this is where we're going to talk about things like our anticonvulsants, local anesthetics like lidocaine, either transdermal or topical, tricyclic antidepressants, which we'll talk more about in the behavioral section later on in the class here. But basically, because the pain is coming from the nerves, not necessarily from the tissue itself, then you have to treat it differently, right? So most of the time, we're giving things to help stabilize those neurons such that they're not going to be sending those really painful signals there. So there's a lot of varieties here, right? So for instance, we've seen things like capsaicin before, we've seen our antiepileptics before, or I think skeletal muscle relaxants can be useful for chronic pain. Yeah, there's a pain spasm, pain sort of cycle that happens there where you have pain that occurs, you spasm up, and that causes worsened pain. So a lot of times we can use things like muscle relaxants to kind of interrupt that system there. But lots of different ways we can kind of get around this. In terms of antiepileptics, again, be careful because what's the big side effect with antiepileptics? Sedation, right? So, and again, that can be synergistic with their opioids if they're taking those, right? We've tried things like pregabalin and gabapentin. We've tried things like lamotrigine, carbamazepine. Any of them can be tried. But again, start low dose and titrate it to see how they're going to respond to it. And we know the common side effects there because we will be tested on Monday, correct? Yeah. Ideally, yes. Tricyclic antidepressants, I'll mention briefly here. We'll talk about this more in behavioral. The reason why this is thought to help with neuropathic pain is due to the fact that it helps to inhibit reuptake of norepinephrine, and that is thought to have some additional benefits. So we don't use SSRIs for neuropathic pain, but we do use TCAs because they have that norepinephrine effect. There's a lot of side effects seen with these as well, so things like weight gain, constipation, a lot of sexual dysfunction you can see with these drugs. We'll talk much more about these later, but just know they can be a useful option for neuropathic pain issues, right? So amitriptyline or disipramine, things like that. Local anesthetics are also a nice way. We use this a lot in the surgical setting for local blocks, right, to actually cause a nerve block after surgery. Basically, what these local anesthetics are going to do, we've talked about lidocaine before, right? Where do we mention lidocaine? As an antiarrhythmic, right? And lidocaine did what as an antiarrhythmic? Block sodium channels, right? So it prevents action potentials from being fired. It does the same thing in the neurons too. And so when you apply this locally, it actually prevents this propagation of painful signals up into the spinal column. So why do you think that would be useful after surgery?
Because they're not in pain.
If I can get this to just a block, say for instance I replace a knee and I can apply local anesthetics just to the nerves that would be sending those fibers there, what happens do you think to my overall opioid use? Goes down dramatically, right? And so there's a lot less side effects seen with just a local anesthetic than you would see with, say, systemic opioids. So we use that a lot. We do a lot of peripheral nerve blocks. For that NUS procedure I mentioned in the prescription assignment, we actually do peripheral nerve blocks on either side of the chest. So we actually have two of those running on each side of the chest there. I didn't include that because that was too much research for you guys, and I didn't want to be too mean. We have other things like topical products like Imla cream, which is like lidocaine and prilocaine mixed together, can buy topically, or things like lidoderm patches, which can be used for like post-herpetic neuralgias and things like that. Very, very helpful for those sort of things. As I mentioned, in terms of other anesthetics, you can use things like ropivacaine, bupivacaine are typically used for either local blocks, or we can actually use it for epidural use, right? Where would I see that used most commonly? Yeah, labor and delivery, right? So you can give, typically we'll see a combination of fentanyl and like ropivacaine for a lot of epidurals that we're going to be using. What do you think the benefit of an epidural is? Especially like in thinking about someone who's undergoing labor. It kind of works at wherever it's sitting at in the spinal column. So typically we'll have these patients who'll be kind of sitting not straight upright, but they may be kind of at an angle. And so depending on where, how much you're infusing the drug there, you'll see it will kind of go up to a certain point within the spinal column. Because if a lady is getting ready to give birth, where do you want that pain relief to be happening? Basically from the waist down, essentially, right? Do you need it go all the way up to the chest and further up? No, you don't need it all the way up there. So by using epidural, you can keep it kind of localized to those areas there. And it basically, based on how they're laying, you can actually find either more or lesser effects there. It's not just how much you're infusing, but the position of the patient can have an effect on that as well. We'll talk more about that in the surgical setting later. I have some interesting stories to talk about, at least with my personal experience with family members getting epidurals before birth. Namely, husbands, just don't say anything if possible to your wives during that whole process. Just be a silent observer the whole time. Anyway, looking at the muscle relaxants briefly, we have a lot of these available, things like baclofen, cyclobenzaprine, metaxalone. All these are very good skeletal muscle relaxants. They actually work through the GABA B receptor, right? We talked about GABA A, meaning what works on GABA A? Our benzodiazepines and our barbiturates are the big ones, right? Those are the big ones that cause those chloride channels to open up, allow chloride to flow in, and hyperpolarize those nerves. Those are GABA A receptors. Here we're looking at GABA B receptors here, and so these are going to be working to help decrease that muscle relaxation or increase muscle relaxation by helping to prevent that spasming from occurring there. We actually do this a lot for our patients who are getting scoliosis surgery, or basically we're trying to straighten out their spine. As you might imagine, those back muscles might like to spasm up because of that pain post-op, and so we'll actually give them metaxalone. That's the one we kind of go with. So they'll get not only diazepam to work as a muscle relaxant in and of itself, they'll also get metaxalone as well, and that way they can help to prevent that spasming from occurring, trying to keep everything straight there. Be aware these have a lot of side effects similar to things that work on GABA A, so sedation, incoordination, ataxia are all going to be pretty commonly seen with these as well. So you do want to be careful with that, especially when you start mixing and matching them together. I've talked about capsaicin already. Remember, it activates substance P release, so it actually helps to desensitize those nerves over time. What's the important thing to remember with capsaicin? You have to use it consistently. If you stop using it, that's what's going to happen. Pain's going to come back and start using capsaicin. It's going to be painful again, right? Because remember, it's uncomfortable the first several times you're using it until you deplete that substance P there, right? And what do you always tell them to educate on after you use it? Wash your hands. Is just water good enough? No, you need soap and water, right? Because the stuff is lipophilic. It'll stay on the fingers if you still just use water, right? You want to use soap and water, or gloves. Can also be another way to prevent that from occurring. Tramadol, this one actually is sort of opioid-like. It does have some effect at the mu receptors, but we do see some additional benefits of it helping to inhibit things like norepinephrine and serotonin uptake. So it's kind of like a mixture of like a TCA plus an opioid. And so this used to be a non-controlled substance, and in fact, it was pretty popular because providers like nurse practitioners and PAs could write for this sort of without restriction. Before you had the ability to get a DEA license. So I saw a ton of this. But again, patients could still get some addictive potential out of this, and a lot of patients abused it because it did not have any restrictions. So it actually got bumped up to a C4. So now that doesn't fall under those particular restrictions, 6 months supply or refills and things like that. Sometimes you see a combination of tramadol and acetaminophen. So remember to watch out for your total acetaminophen amount you're going to be getting in there, okay? This one's interesting too, though, because normally you still have to worry about the typical opioid side effects from overdose or from abuse, sedation, CNS depression. You also have to worry about things like seizures that can occur from this, and that's mainly due to that norepinephrine reuptaking effect. So it could be another interesting side effect that can develop from that. Then medical marijuana. We maybe mentioned this just briefly, probably with like GI. We were talking about Marinol and Sesamet. Did we mention that briefly? Okay, so medical marijuana, how much do you know about this stuff? What can we use it for? A lot of things, right? So that's kind of interesting. So in 2016 is when we actually had medical marijuana in Florida legalized, and so it's interesting how they kind of talk about it in the law here. Here's all the things they list that you can use it for, but I like this statement at the end here. And basically it says, if you think it might work, go for it. So there's a lot of leeway you can see with this for sure. Does medical marijuana work? To each his own. Does it have efficacy? Yes. It can be effective for a lot of different things. Is it going to be first-line treatment for any of these things? No, right? So typically, and kind of what they mentioned, and I have a couple articles I mentioned, like in JAMA came out in 2015, they had like a big position statement basically saying that, yeah, it can provide some efficacy here, but try stuff that's tried and true, right? Try the gold standards first, and if those are still not working, or maybe your patient is not responding well to it, then you can try the medical marijuana, see how they respond to that. So there's some caveats here to worry about with this. What is the sort of the main components of medical marijuana that we get kind of the most therapeutic effect from? It's THC, which is delta-9 tetrahydrocannabinol, right? And then there's what else? CBD cannabidiol, right? There's a lot of other products that are in there, but certainly these are the two main ones we're going to talk about. And THC is really the main psychoactive one, right? That's the one you're going to see kind of that euphoria and those kind of effects from. Cannabidiol tends to be better for sort of the neurologic symptoms and whatnot. So for instance, there is one FDA-approved product called Epidiolex, which is just pure CBD that is used for certain pediatric seizure disorders, okay? You guys ever heard of Charlotte's Web? That was actually a formulation before medical marijuana was legalized in Florida. We did have the access to Charlotte's Web, which is a special strain of marijuana that was engineered to produce high levels of CBD with almost no THC, and that was used for those same seizure disorders. We had a couple of kids who were actually on that for their seizure disorders. We do have cannabinoid receptors in the brain, CB1 and CB2. I'll mainly focus on CB1 because that's responsible for most of the clinical effects we're going to see here. And again, it has a pretty complex effects on different neurotransmitter systems, difficult to determine sort of what the exact mechanism is for a lot of these. Are there any risks with using medical marijuana? Like what? So they should not drive. Why should they not drive? You're under what does that mean when you're under the influence, though? You're high. What does that mean, though? Why is being high not good when you're driving? You can have impaired reaction time. You can have ataxia. You can make poor judgments, right? You think, hey, that car's not that far away. I'll go ahead and it's far away enough. I can drive out into this intersection. Maybe not, right? The most common reason why patients who are under the influence of marijuana come to the hospital is what? Is it because they are having a bad high? No, it's because they get into a car accident or something. It's trauma is the biggest reason why they come in, right? Some people do come in because they're way too high. I'll talk about mentioning that in just a few minutes here. But because some patients do have a bad reaction to it, they can get hallucinations and kind of get really paranoid when they're on it. But those effects are more rare than not. But certainly the sort of the CNS depressing sort of effects, the impaired memory, short-term memory, motor coordination, those are the big things you worry about, at least from the acute sort of ingestion. Is marijuana addictive? It's a Schedule I substance, right? So according to the DEA, yeah, so there could be some psychosocial sort of components to it, but certainly not addictive in the terms of what we think about things like cocaine or opioids and things like that, right? Certainly you don't see strong withdrawal sort of effects from this. So overall, again, if I had to have someone say, do black tar heroin or marijuana, probably say which one's safer. Obviously black tar heroin, right? So we just know that's obvious. No, marijuana, it's super safe, right? As long as they don't get behind the wheel of a car and they hit somebody, things like that. So chronically, there could be some effects though, right? We don't know chronically, we don't have big, huge studies looking at chronic use, and why is that? Because it's illegal, right? It's a Schedule I substance. It's super hard to do studies for this kind of stuff. So we don't have a lot of long-term studies to know what the issue is. The things I do want to point out, though, are going to be the dosage forms that you're going to be using most often with these, right? So what are the two kind of most common dosage forms for marijuana? Inhaled and oral use, right? Those are the two most common ones, right? What's the problem with inhaling? Say you're lighting up a joint. You're inhaling that. What's the problems there? You get, pulmonary side effects, right? So if you have reactive airway disease, it can aggravate that. Pyrolyzing that stuff, that hot gas, is just as bad as cigarettes, and from that standpoint, you can actually cause damage to the cilia there. You can lead to infections, bad problems overall, right? So using things like vaping solutions and e-cigarettes and things like that may get around some of those problems because the gas is not nearly as hot. But again, we don't know a lot about what's co-formulated with a lot of those products, right? They have other things that solubilize them and congeners and whatnot that we don't know what the chronic effects are. So there could be some risk there, but that's vaping is probably going to be a much safer option for a lot of those patients there. In terms of onset, what do you think is faster, oral or inhaled? Inhaled, 100%, right? It's going to have much faster onset. Oral, how long does that usually take to kick in? 30 minutes to an hour. So, and you think about you think about oral dosage forms of marijuana, what do you normally think about? Like gummies, okay, what else? Like brownies and edibles. Remember butter? Yeah, why butter? It's highly lipophilic, right? So THC is highly lipophilic, which is why you usually put it into things like butter and brownies and pizza and all kinds of different stuff, right? So because it is so lipophilic, That's the reason why, for instance, like, drug tests can be positive for a really long time on THC because it gets into your fat, especially with chronic use, and it leaches out over a long period of time. The thing to think about, though, is that you have to be really careful with the onset of action. It's going to be much slower for edibles than you're going to see for an inhaled form, okay? And so to give you an illustration, I found some interesting news reports, and there's some good studies that were coming out from the Rocky Mountain Poison Center up in Colorado after they legalized it for recreational use. And one of the things they want to look at to see were there any changes in ER visits after they legalized it for recreational use, okay? What they found is that for the most part, there weren't big changes, but the issues were patients who were underestimating edible products. So here's a clinical scenario, right? So let's say you are going to Colorado, let you go for recreational use, and say, I'm gonna go get me some brownies, right? And so you ingest a dose, you wait 30 minutes, and nothing's happening. What do? You take another dose, okay, so I get another dose, okay, wait another 30 minutes, nothing's happening, what do? You take another dose. So they end up dose stacking, and by the time it kicks in, it can take up to 90 minutes or so for these. And actually some products will have information on there saying that, listen, don't keep eating the stuff, like give it 90 minutes to kick in. They got way too much all at the same time, and so basically they would actually call 911 because they were just like way too high. They just could not even get up and walk. It was just bad news for them, right? They call it couch locked. I heard one article call it, and they're basically having those paranoid delusions and things like that. So that can be really bad from that standpoint. So just be aware of those changes in the kinetics of it, okay? Anyway, overall, though, they do find there is some evidence for use. They do find some additional benefits from these in these disease states, so it's not completely out of the question. Things like appetite stimulation is a really good thing with patients with end-stage AIDS or HIV, because again, what happened, or chemotherapy patients, because what does marijuana do to your appetite? Get the munchies, right? So you want to eat stuff, which is great because it's going to actually help you to put on some weight if you have some of those conditions where you have a lot of wasting, right? In terms of it being an antiemetic, it actually works pretty well for that. I mentioned the hyperemesis syndrome, though, you can see with that. What was the thing that helped out with the hyperemesis syndrome? I remember hot showers, hot water can actually help out with that. But basically, they said that you can, again, try the standard stuff first, try the gold standards. If those are not working well for your patient, then you can try medical marijuana to see how that's going to respond. But again, be aware of patients who have underlying not really well controlled behavioral health issues. They may not be good patients for that because it could be more at risk for those paranoia and delusions and whatnot. So anyway, pain management is pretty complex, and everyone is going to be individualized for every patient. And if you can, try to reach out to experts, right? People who do this as a specialty, because they may be able to give you some more ideas than just say throwing opioids at the problem. You can try other things that can really help you out with that, right? Anyway, real quick, just from an ortho standpoint, I want to mention venous thromboembolism here. We've kind of covered most of these drugs already, but why are patients at risk for VTEs after, say, a hip replacement or a knee replacement? Because they're laid up, they're in bed, right? They're not moving around. So the blood is being very static, right? Anything else? Just the injury itself of the actual surgery can increase coagulability, right? And again, what's the best thing for these patients after surgery? Get them up and walk them around, right? But in some cases that may not be possible, right? So, and again, this can develop as DVTs, but that can eventually lead to PEs in some cases there. Obviously, risk factors are multiple, right? So certainly if they're in any kind of hypercoagulable state, like pregnancy is a big one we worry about. Why are pregnant patients more likely to clot? A lot of estrogen, right? Estrogen tends to cause more clotting factors to be formed in the liver, thus they are at risk. So by that transitive property, who else is a big risk for clots? Women who are on birth control, estrogen-based birth controls, they're at really big risk as well. So if you ever hear a young lady who's on birth control and a smoker, that's a classic story for something with chest pain to the ER and to get diagnosed with a PE, right? Very, very classic story. But yeah, so these are other things you would really want to consider. There's certainly immobility, obesity, all those are going to increase their risk as well. How do we treat this? If they've got a clot, the aspirin. So aspirin could help, right? Could be an antiplatelet drug, but if they have an active clot right now, I probably want to go with something a little bit bigger. So what could I use? Heparin. Heparin's a really good spot to start out with, right? Because again, we want to deal with these actual clots that have already formed, right? We want to deal with that fibrin. We want to deal with all those platelets that are plugging together when they're forming that thrombus, right? So again, look back at your anticoagulant slides because we can talk about how these are going to be important for use here, right? So for instance, you mentioned heparin. How does that drug work? Remember, it helps antithrombin 3 to inactivate several clotting factors. Remember what are the two main ones we talked about? 2 and 10, right? You're driving a car, right? 2 and 10. Those are the big ones we mentioned. The heparin helps to inactivate. There are other ones as well, but those are the main ones there. Remember that heparin works pretty much immediately. What else could I use instead of heparin? What else? Heparin is just too big. I want to cut it down to size. Low molecular heparins like Lovenox. What's the generic? Enoxaparin. Very good. What does that one work on? A little bit of 2, a lot of bit of 10, right? Remember? How do I monitor for the effects of heparin? What lab test do I draw? APTT. What if I was trying to measure the anti-10 effects of Lovenox? Anti-10A levels, right? Because it's going to be more focusing on factor 10, right? Remember now, and actually we're starting to move more to nowadays, remember we have these new oral agents, right? Because before, if we needed an anticoagulant, what do we use for long-term prevention of clots? Use warfarin, remember? But what was the problems with warfarin? You had to monitor, what would you monitor it with? PTINRs, you got to do all this monitoring. What affects the anticoagulant effects of warfarin? Vitamin K intake or lack thereof, right? Remember how increasing vitamin K intake does what to your INR? Decreases it, right? Because again, you're making more clotting factors because warfarin's a vitamin K antagonist, right? Nowadays, we have the new oral anticoagulants. So remember, we have things like apixaban, rivaroxaban. Remember which one factor they worked against? 10. How do you know it's 10?
X.
Remember, there's an X in the name, so you can know, like a Rixtra or Fondaparinux has an X in the name, so you can think working more on factor 10, right? They have dabigatran, which is actually a direct thrombin inhibitor, so that's working more on factor 2. But I'm starting to see nowadays that more patients are just getting started off on oral anticoagulants right at diagnosis rather than having to go on a heparin drip, right? So that's actually been a big move as of late. We're starting to see more evidence that is equally efficacious, which is nice. You don't have to start an IV in those patients potentially. But anyway, in terms of prevention, usually what we're going to end up doing is either doing preventative doses of enoxaparin, or you could do sub-Q heparin, right? So you could do intermittent dosing of that. That's typically most common for prevention, especially if they're really high risk, if they're not moving around. We do this a lot in patients who are, say, in the ICU and they're immobile and they're sedated and ventilated. Maybe they're paralyzed in some cases, they can't move around. We oftentimes will give them heparin or Lovenox in order to prevent clots from happening. Is there any like physical ways you can prevent clots in those kind of patients? Yeah, the sequential compression devices, SCDs, if you see those big things on their legs, they're kind of sequentially pumping their venous blood and keeping it from being too static. That can be useful. But really the best thing is just get them up and move them around if possible, right? So kind of the best thing to prevent those from occurring. So anyway, so let's say we have someone who has an actual VTE that has been detected, right? So maybe our prophylaxis was lacking, or maybe the patient has a hypercoagulable condition, something like that. Again, figure out, okay, are they going to be a good candidate for anticoagulation or not? This is where things like vena cava filters can be useful here to actually prevent clots from getting up into the actual lungs themselves. But let's say patient does not have any contraindications. This is where we can focus on things like, okay, well, how sick are they right now, right? You know, is it just a DVT localized to the leg, or are they actually having chest pain? There's actually a clot in the lungs causing some acute symptoms here. In those cases there, if they're having like a massive unstable PE, you know, sometimes we'll actually give, you guys remember that clot buster we talked about last semester? Last decade we talked about it? But TPA, remember Alteplase was the one we talked about. Sometimes you administer that. That's really for the most life-threatening. Most of the time, though, you just start up on our anticoagulants, right? So we can either start with like Lovenox, or we can start with our heparin. Usually that heparin has to be given via infusion because of the short action of it, right? But as I mentioned, more and more patients are now just getting started on something like apixaban, right? That's going to be good enough. You get very similar clinical effects there. But looking at this, again, this might be slightly out of date because they don't include as many of the rivaroxaban was kind of the first one they started using. Apixaban you could add to this list too. But again, why would I not want to start off a patient who's having an active VTE on, say, warfarin? Yeah, remember the onset of warfarin is delayed. Why is that?
Because what's produced.
It doesn't work on the already active clotting factors. It only decreases their production. And remember, if anything, warfarin puts you in a hypercoagulable state initially. Remember, we talked about bridge therapy. We'd have them on heparin or Lovenox for a period of time and then you start them on warfarin at the same time, and then once their INR is good, then you take them off the heparin, right? It's a bridge therapy because you worry about them having a hypercoagulable state initially when they start warfarin there. But, and again, the next thing you have to worry about is going to be for more long-term prevention of use, right? So for instance, if they came in and they were on oral birth control, and that's what caused them to have the clot, what would you do for them? Stop the birth control, right? So there are other ways you can, give them birth control. There's intrauterine devices or progesterone-only based things, which we'll talk about later. You have to look to see was there any reversible causes, or if there are irreversible causes, then you have to consider long-term anticoagulation. So a lot of these patients will end up being on at least 3 months or so of like something like rivaroxaban or apixaban in order to prevent any recurrent clots from happening there. And then you kind of assess kind of where they're at, and if they don't have any further ongoing concerns for causing a clot, then you can cut them off. Otherwise, they may need to be on more long-term therapy depending on the risk factors. So anyway, so any questions on that? Should I check the results of the poll?
Yes.
Oh my goodness, I can't wait to see what they show. What if I like cut off the video real quick and then I was like, give you some extra suspense? Is lean dangerous? What is lean? Lean, what's another name for lean? It is promethazine codeine. Otherwise known, what's the other names for it? Scissor or purple drank, yes. So usually it's a mixture of vinegar and codeine plus alcohol, or you could mix in some other things. But yes, it is dangerous if it's not been prescribed to you. What's the risk of mixing codeine and Phenergan? Respiratory depression for sure. What do you think about the CNS depression associated with that? Really good. Remember, Phenergan will knock you out because of the anticholinergic effects. If codeine on top of that, for sure it's going to cause some issues there. So I would not recommend it. There might be some musicians out there who would, but again, who are you going to listen to?